Right, I have 7 a.m. on my watch.
Yeah.
You have a quorum? I will call the Yellowstone City County Board of Health to order. If you have any guests in the room that would like to address the board, seeing and hearing none, do we have any online who would like to address the board? Hearing none. Our first order of business is approval of last month's meeting minutes.
Move approval.
Second.
All in favor?
Aye.
Motion carries.
Jim, I have a question there.
Yeah, Coach.
On the CMO report, it said the class of interns. And I really think it's first year residents, right, Megan?
Yes, first year residents are interns.
So we can change that.
They're called it, they're interchangeable, but interns are first year residents. Some residencies do your internship in a different, like a transitional year internship, but we call them interns.
All right. John, a report, please.
Thank you. That report.
Okay.
CEO health report is attached. First and foremost, I think we'll address on behalf of the largest public health entity in Montana, us, RiverStone Health, mothers and parents of neurodiverse children. RiverStone Health echoes the statements from the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, the Society of Maternal Fetal Medicine, and so many other professional organizations and healthcare professionals across the country who have all come out in strong opposition of the misinformation being shared from the federal government as it relates to acetaminophen, it's the correct pronunciation, and Tylenol. More than 2 decades of research have found no causal link between acetaminophen use during pregnancy and autism, or ADHD, or any intellectual disability in children. And I want to make sure that the public knows that acetaminophen continues to be an important and safe option for managing pain and fever during pregnancy. Conditions that can pose serious risks to pregnant patients and their fetuses if left untreated. So Tylenol and acetaminophen, paracetamol, continue to be safe for use in close consultation with your personal medical provider. Now on to the good stuff. AED, we were able to acquire and donate an AED for our Huntley Seniors Group. Thanks to Amanda up there at the Warden Clinic, who will be able to help the Huntley Seniors Group train on the use of that AED, and we're going to be getting them a case to store that securely as well. So that's a near and dear to my personal heart. My Eagle project was back in the day was getting AEDs out into public locations and helping train folks on their use.
What is the cost or something like that?
It was about $3,000. Yeah. But that was our opportunity to give back to the community and get them a necessary life-saving device. So it was good work. Let's see. First and foremost, more federal changes. Some changing federal policy for vaccine recommendations. Last week, the ACEP panel, the Advisory Committee on Immunization Practices, met to discuss vaccine recommendations for new children, and they called themselves rookies. So I think that just means they're all new people. Bottom line up front, I wanted to share the MMRV vaccine, that combination vaccine, that was removed from the childhood vaccine schedule for children under 4. We carry that as part of our Vaccines for Children program, but we only provide it as a second dose. Medical guidance for a while now has questioned the utilization of the combined MMRV vaccine, We give 2 separate doses, one of MMR and one of varicella as the first dose, and have for a while. Nothing about the MMRV decision changes the guidance for the actual MMR vaccine and separate varicella vaccine at birth. And so that remains best practice and ACIP guidance. ACIP voted not to change the childhood vaccine schedule for hepatitis B, fortunately, and to table that vote and not make any more recommendations on Hep B. And so while mRNA vaccines, such as our COVID vaccines, do not alter our DNA, hepatitis B actually does and has the ability to. And that mutation of our individual DNA from hepatitis B is what leads to liver cancer. And so that is why we vaccinate, one of the reasons we vaccinate against hepatitis B. All 12 members of the ACIP panel voted to maintain approval for COVID-19 vaccines. And all 12 members actually voted that the COVID vaccine is beneficial for those at high risk of severe illness from COVID-19. Their recommendation is that for individuals aged between 6 months and 64 years of age, vaccines be based on individual-based or shared decision-making. That's the new language, along with an emphasis that risk-benefit of vaccination is most favorable for those at an increased risk of severe disease. And so what this fortunately means is COVID-19, MMR, hepatitis B vaccinations will be readily available for all Montanans who wish to receive them. They are safe and highly effective. And now that ACIP has approved the utilization of those vaccines, they are going to be covered by all insurers, including Medicaid and Medicare, with the acting CDC director's approval. And so once the CDC approves the committee's recommendations, that then will trigger the coverage. America's health insurance plans came out also last week and said no matter what happens, we will cover them through this 2025 plan year, but don't give them too much of an ethical pat on the back. They're statutorily required to do that because they can't change the way that they administer their plan benefits in the middle of the year like that. So we'll see what happens in 2026 plan year. So we're going to be closely following this shared clinical decision-making recommendations. It will be a conversation between the individual patients and their medical provider, based on to respect, right, personal choice. But that new language has the potential to result in some access issues and gaps in vaccination, further contributing to our lack of herd immunity in some cases. So we'll continue to follow it closely. And there is a call this week later today with public health across the state to understand what this means for public health's ability to give vaccines and what the definition of a clinician or a provider is going to be, because our immunes nurses already do this shared decision-making practice with our patients and counseling and sharing the benefits, the costs, the risks, and all of those things as it relates to vaccination. My computer battery is running low, so apparently it's not actually plugged in down. Note on measles, COVID-19 in the state of public health. I think y'all can read what's in the report this morning, but unfortunately we are continuing to see resurgence in vaccine preventable illnesses across the United States. Specifically regarding COVID-19, the science behind the vaccine has existed since the 1990s. That hasn't changed. With the development of the lipid nanotechnology, that created and helped us create the COVID-19 vaccine that saved millions of lives and allowed the human body to recognize the COVID virus of a new novel vaccine virus. The uptick in measles this year also continues to be our canary in the coal mine, telling us that we are losing the battle for the public's trust and need to take some new approaches to managing that. But I want to make sure that the public knows what we're seeing with the COVID virus right now is that our bodies are building immunomemory. It is doing so at the cost of 1.2 million American lives. Those are 1.2 million neighbors, friends, family members that are no longer with us because they succumbed to a new novel virus. That is what has the potential to happen if vaccine hesitancy continues and we see more measles, or we see polio make a resurgence, or we see hepatitis B come back in infants. More people will die as a result because our immune memory is not built up to those viruses and illnesses. So that is why vaccination is so important. Hopping off my soapbox this morning, we had an opportunity coming up Wednesday, October 8th. Our hospice staff and Tamarack Grief Resource Center will be hosting a camp for children's day camp 1 to 5, grades 1 to 5, for those who have lost a loved one this year. And so it's a grief resource camp and available to any children in grades 1 through 5 that have experienced a loss this year and would like some assistance with that. We had some really good success with back to school vaccination clinics this year. And went down with the WOW, the mobile unit, to Bridger and Joliet to help provide some vaccines. Saw 41 patients in Bridger and 63 patients in Joliet. So not too bad for well-child exams, sports physicals, and vaccines. We have a blood drive coming up today. If anybody's sticking around campus and wants to get stuck, you can donate blood at the Vitalant van today. I think they still have an appointment or two available. Tomorrow is the Suicide Prevention Conference, annual conference we put on. Last week, held Question, Persuade, Refer, QPR training for the community and continue to do all we can to prevent suicide in our community. Also tomorrow, State of Mind, which is a project from the University of Montana, and the Traveling Theater Group will be coming to our campus, RiverStone Health, for a community meeting and conversation on suicide prevention and youth behavioral health. This group, State of Mind, has been in SC2 all week and has been doing two sessions a day at every high school throughout our community, focusing on removing the stigma from talking about behavioral health, talking about suicide, and talking about mental health resiliency for our youth. And so, great free program from the University of Montana, and we're going to have another good discussion tomorrow on how we can make an impact here. We continue to benefit from Cushing Terrell's golf tournament for our Kid Connect services. We'll hope to get a check from them in the coming months. And I just wanted to make a public announcement that we are currently recruiting for Chief People Officer, a senior executive leader for human resources here since the retirement of Jeff Hurt and departure of Alexis Urbanic. We want to continue having strong people culture here at RiverStone Health. And so if you know any qualified individuals to help us lead in HR, please let me know. The partnership with our Catholic Social Services is evolving. They are moving into a bigger space at St. Patrick Cathedral. And so they'll still be downtown, and we will still accept donations on their behalf. but they will no longer be housed on our campus. They'll be over at the Cope Cathedral. August last month was the worst month this year for overdose in Yellowstone County. We had a spike downtown, over 22 reported overdoses, and of those, only one was fatal, fortunately. But the largest hotspot was downtown, and it spread out into areas of North Park and Pioneer Park. So wanted to bring that to the board's attention and community's attention, and talk through how we're working to continue to prevent overdose in the community. One of the ways we do that is by getting naloxone out into the hands of individuals and organizations across the community. And so our recent lunch and learn was for staff and volunteers. All staff were provided with Narcan and tools and how to use that as a life-saving device for someone who's overdosing. Additionally, one of the reasons I want to talk about this is to clarify, let everybody know that, secondhand fentanyl exposure is very, very difficult. Fentanyl is not readily absorbed through the skin. And people who have overdosed or are in the process of overdosing need your help immediately. And so talking about secondhand fentanyl exposure and debunking some of the myths around that helps Good Samaritans feel comfortable to walk up to somebody and administer nasal Narcan. It is highly unlikely to overdose or experience any adverse effects from fentanyl just by handling pills, handling powders, or handling liquid. It takes a very specialized formulation to go through that intradermal absorption pathway using a fentanyl patch. Those are prescription pain patches. That is a special formulation made to be absorbed through the skin. Because election season is coming up, I also field this question from county and state election officials who are worried about potential fentanyl exposure through powder specifically, via mail-in ballots or other mail. And again, both OSHA and DEA research have concluded that contact, just touching that powder from an envelope, it is very highly unlikely for you to experience any OD effects. We see videos, we see reports from law enforcement sources and from other sources across the country that feel like they are, overdosing because they touched a vehicle that had fentanyl within it. And so I'm here to dispel the myth that that is most likely signs and symptoms of anxiety and fear versus actual drug overdose symptoms. The risk becomes if you're touching that powder and you then touch a mucous membrane or you touch your mouth and you're orally accepting that, or you're breathing high concentrations of powder in. Can I borrow that? My computer died. And so I wanted to talk through that and let folks know it's safe to walk up to somebody experiencing overdose and administer Narcan. And we'll also provide Narcan training for anybody who handles mail, who works in the election office, etc., to make sure that in the event that something does rarely occur, we're able to address it. Last thing I wanted to address was the measles update and some other novel virus issues. We've got some additional cases of measles across the country. Fortunately, no additional cases here in Montana. However, on Thursday, September 11th, health officials in Los Angeles, California, reported the death of a child from subacute sclerosing panencephalitis, or SSPE. That is a rare but fatal complication that occurs when young infants are exposed to measles before they can be vaccinated. It happens between, it can take almost a year to come up and show up and present in a child. But in a child that has fully recovered from measles, as long as they were exposed at that young infant stage, they can develop this encephalitis fatal illness. It is a progressive brain disorder and a complication of measles. And that is why, again, it is so important for us to continue sharing the importance, the safety, and the effectiveness of the MMR vaccine across the population. It's an incredibly painful reminder of how dangerous and deadly measles can be. We also had last week pertussis death reported. There's some complexities behind this death, but unfortunately, a female resident in their 70s passed away after acquiring pertussis. We confirmed that it was actually pertussis, and unfortunately, the individual had several additional conditions that made that illness fatal. But again, this is the first since 2019, first death in pertussis since 2019. Again, just sharing how important it is to get the Tdap or DTaP vaccine to prevent pertussis. That was a long report this morning. Thank you for your attention. The last thing I wanted to share with all of you around the table is I had the chance to pass out our elevator speech and mission, vision, values, core strategic pillars document that we'll be talking with staff about. But I wanted you all to have that as board members talking through our strategic priorities here at RiverStone Health. Questions? A lot after this one.
Any questions for John? Hearing none. Megan?
Great. I think John covered a lot of the medical topics. I'm happy to answer. I think he covered most of the important points. I'm happy to answer any other questions about those. Going over my report, so I didn't include a lot of that in my report because it felt duplicative. The things that we didn't really discuss, I think so residency season started yesterday, so applications are open. We're starting our search for our new group of residents, which is very exciting, which is going to be the class of 2029, I think, or 2010. It's crazy. It seems so far away. Like it is a little surreal. We talked a lot over the last 6 months about the need for an APP residency. So a residency for advanced practitioners who are nurse practitioners and physician assistants. And we've tried to figure out how we could make that work here on our campus. So a residency is not required for either of those disciplines. They come out of school and then start directly in the field that they are hoping to practice in. There's sort of a growing movement right now because we're seeing more APPs practicing independently in different states. There's been more of a push to have a residency for people who are coming straight out of school. And we will be launching our first residency this summer. So applications will open in January with the plan to take 2 residents a year. We'll be able to provide them with, we already have been taking about 2 new grads a year and have been kind of doing this informally. We have the luxury of having the family medicine residency program, so a lot of the structure already exists. So Wednesday afternoons are didactics for all of our residents where they get lectures from a number of us faculty. We also invite in outside physicians to come in and give lectures on their areas. So our APPs who are in their first years of practice have traditionally joined them and had the benefit of having those lectures. So now we're just formalizing it more. They'll be able to get an experience in pediatrics and specialized population and geriatrics. We plan on having them do a rotation up at the hospital. They were working with Rimrock to try and get them an experience with inpatient substance use disorder treatment, Hep C treatment. So we are putting that together now, and we should have, did we include on the back page, you actually have the flyer that we have created. It's still a little bit draft, so don't go sending it to all of your best friends quite yet. But that's we are planning on starting to recruit using that tool, and our website is getting up and running. So that's very exciting. Other things that I wanted to talk about also along the lines of workforce development. Two other things to point out. As we've talked about, we've had a significant shortage of MAs that has really been limiting having our staffing providers in clinics. So now we have this clinic with lots of space, but not the support staff to put our providers in positions where we're able to see patients. So we are, and part of that challenge has been multifold. One of the challenges is that we just haven't had a great pool of applicants of experienced MAs and certified MAs who are applying to those positions. And so we have again tossed around, how do we grow our own? Would we be able to put together an MA training program and again, we already have a strong onboarding process for those MAs, but could we actually formalize that and even potentially in the future look at paying for them to become certified by taking the national exam? So we are putting that together now and are hoping to be able to get that up and running in the next year or so. Also along the lines of shortages has been our behavioral health providers. So we are trying to expand our behavioral health program, particularly in pediatrics, and we're having a difficult time recruiting into those positions. Again, multi reasons why that is the case, and some of that is wage related that we're trying to manage. The other challenge is just having qualified candidates. So LCPCs and LCSWs, they graduate with their graduate degree, but before they can be independently licensed to see patients on their own, they have a large number of clinical hours. I think it's close to 3,000. It might even be more than that they have to have in a supervised environment. So during that time, they're sort of like residents, they're considered candidates. And we have historically not taken on candidates just because of the amount of work that goes into doing that. Again, you can't expect people to be seeing patients and then also supervising new grads. And so it really has required us to look at how we use our current experienced providers a little bit differently to decrease their load, but then increase their capacity to supervise others. And there's training that goes into that. Like, just because you're a good doctor doesn't mean you're a good teacher, right? And so we're working on trying to figure out how can we get more of our behavioral health therapists who are trained and experienced, comfortable with supervising candidates. And we've taken on, I think we have 2 candidates now, and we're looking to expand that so we can expand that. Few other just faculty. So yesterday was our faculty meeting. We spent a lot of time talking about, besides how do we teach better and support our residents better, how are we going, and I'll bring these graphs because Dr. Brand and Dennis R. Green created the map of the growth in students that we're seeing in Montana, which is in the medical field, which is fantastic. We're going like over the next 10 years, I think we're going to see like a 450% growth in PA students, NP students, and medical students that are coming out of Montana. And on the one hand, that is fantastic. On the other hand, we have to figure out how we're going to clinically support those programs, because it's not just graduating the students and the residents, you have to have them trained appropriately in clinical settings. And when they've looked at so far, what's the projected increase in capacity of clinical rotations, it's something like 26%. Clearly is not mapping the growth in students. And so we had a long conversation yesterday about how we as a faculty group are going to figure out how can we expand, here, what capacity do we have to expand clinical rotations and our ability to take on more students. It is not going to be 400%, I can tell you, but I think that this is a conversation that we need to start to have across the state. So it was a great conversation. All of us are super motivated to teach and super motivated to have more students. We just want to make sure that we're creating a very good training clinical, and maintaining a good clinical training environment. We also, so as John sort of mentioned, so this month is Suicide Prevention Month. Montana has been held in the top five spots for the highest suicide rates per capita for the last 30 years. And so, mental health continues to be a significant, issue for our state. It was interesting when we did some of those outreach clinics for sports physicals. They've now changed on the Montana sports physical. They've added a little section that screens for depression and anxiety, which I was really happy to see that they've added that on. They also have decreased the requirement for sports physicals to be every year to every other year, which I really disagree with, because I feel like that's one of the only opportunities that adolescents get to get in front of a medical provider. But it was amazing. We didn't have a lot, but we had a handful of people who came to those appointments who said, I'm not going to let my child fill out those questions because it's because you're asking questions like that we have all of these mental health issues in our state. And I was like, wow, I wish that I had heard that directly, because we don't get to be the top 5 in suicide rates because we've been out there on the front line talking about depression and suicide. I can tell you our state has not been on the forefront of, shining a light on this issue. And so that is not actually an accurate correlation. It's actually opposite. This state of mind, I've seen this presentation twice. So as John said, it's the University of Montana and it's the Montana Repertory Theater, which is a professional theater in Missoula. And they've been traveling around the state specifically on this topic of how do we bring to rural communities, how do we bring the topic of mental health to these rural communities, and how do we do it through youth, right? Because youth are the ones who often shed the light on things that we need to see. So the community conversation is tomorrow. The public theater performance is tonight, and it's at 7:30, and it's at the Lincoln Center. And they do a series of vignettes that this theater troupe does that highlight all these different areas of mental health, and it's going to have and it ties in some of the conversations that our local youth have had. So I strongly recommend that you go, that you tell people about it, that you get people there. It's a free performance, and it really is absolutely fantastic. Other than that, I think everything else is 2 big shout outs to our IT and our informatics optimization team. Telehealth is really fully launched on our new platform. It's a great platform. I personally had the opportunity, I had to cancel a session last week or a couple of weeks ago because I had to fly home to Connecticut a little unexpectedly, and they didn't have any staff to be able to cover me for a new session to open up. So I opened up a telehealth session, and I was able to sit in my office and see a number of my patients without any staff support, just being able to click on and see patients. And it was fantastic. So we're really looking at a way that we can expand that to decrease the amount of staffing that we need for our providers. And so thanks to our amazing informatics team for we were all a little hesitant about switching to this new platform. We had a lot of doubts, and it really has been outstanding. And then we also have launched online scheduling, which is something that we have wanted, especially Eric has wanted us to do for a really long time. And we finally have that launched. And that's open for same day care. And our plan is once we sort of trial it and make sure that it's working well, we're going to expand that to more of our clinics. And so I think it's some of these innovations like that and some innovations that we're doing with our Droidal automated bot, which I don't really understand like how that even works in my mind, but I'm glad that it's going to be doing things to decrease manual touching of the electronic medical record and trying to help us figure out not how to just work harder or need more people to do the work we do, but how can we do it more efficiently. And so those are a couple of the exciting projects that are going on. And I will end there.
How much training and education is required to become an MA, and what facilities are available locally to do that?
Yeah, that's a great question. So you need to have a high school degree. And then the training program, it varies depending on the program, but it's not quite a year-long training. And then there's an exam. So right now, and Eric, you might know better than I, charter is still open here. No, charter just closed. So we had one program here that really was an MA certification, like go to class and take the classes and then take the exam. And it was like $30,000 a year, $20,000, $30,000. Like it was a really expensive program, right? And that's hard for people who are trying to train to be a medical assistant, to have that much money up front to invest in a program. And so right now, I don't think that there is a formalized.
Nothing connected with the university.
The only program that's going right now that John came across was the one from the Billings Public School District. Has like their summer adult education
ACE program.
Yeah, and so they're offering an MA certification program through that, but that's the only one.
That's the only, the external one. There's an internal program. I think that the clinic runs, Billings Clinic runs an internal in-house. And that's what we're trying to build too, is say, let's build this internal capacity to have those training programs.
And what we would love to look to do is there an online program that we'd be able to help pay for so that they can get some of the didactics through that online program and then be able to add on to that a really robust hands-on experience between working in the clinic as a student. And we used to take a number of charter students. In fact, a number of the MAs that we have here were people who rotated here as a charter student. But then we also have our simulation lab. And so we have, a whole simulation lab that is set up that our residents and medical students use, that we really, part of it is staffing, is having enough staffing to really support that, that level of training and curricular development.
Yeah.
Was there any sort of logic for the idea of making sports physicals every other year?
I don't know. I mean, I think that on the one hand, when you just look at, the main things that you're looking for in sports physicals, if you're just thinking about a child who's been getting child care their majority of their life and they're coming in before sports physicals, are really musculoskeletal injuries or concerns that you have to identify, and cardiac. So there is one particular cardiac condition that's a congenital cardiac condition that can lead to sudden death on the field. Like that's when you hear about some of these, athletes who all of a sudden have a cardiac arrest. It's one of the reasons why they started putting AEDs, and they have found that has dramatically, impacted, being able to resuscitate, people. So the reality of like finding something like that year to year is fairly small. The bigger picture of getting teenagers who tend to develop that often develop high risk behaviors, year to year as they get older and being able to get in front of a medical provider, I don't think that from an athlete standpoint, they are necessarily taking that into consideration. So I think it was more the pure screening of physical conditions that can impact sports.
Other questions for
Yeah.
Megan? Hearing none. Thanks, Megan. Spencer couldn't be with us this morning. I don't know if he's online there. I've asked Shanna to give us the finance committee report.
Good. Well, good morning, everyone. Included in the packet this month are the July 2025 financials. So the first month of our fiscal year. I'm going to run through a couple of things that relates to the balance sheet and then spend the majority of the time on the highlights that were included in the packet. It's a similar format to what was presented in June, but just kind of looking through some things that might be a little bit more visual to present to the board. Spencer has some ideas related to some graphs and some a consistent dashboard to present to the board. So we'll take a run through that at Finance Committee next month and hopefully include that in the packet for the board at the next meeting. So just a couple of things to point out on the July 2025 financials as it relates to the balance sheet. I'm going to continue the cash conversation that we've had for the last year or so. At the end of July, we're at about $13.7 million in cash. And if we're looking at kind of apples to apples, looking at July of 24, that's an increase of $5 million. We did see a little bit of a decrease from June to July, but that's normal cyclical for the organization. Really based on the fact that we get half or a portion of our mill levy payment in June. And so we see kind of an influx of cash in June and then a dwindle downward as we wait for the next mill levy payment that comes in December. So nothing alarming there, but an overall increase if we're looking at July to July of about $5 million. Of that balance, $10 million is unrestricted, $10.5 million. So we can use it, for more, not the grant restricted money or any of those kinds of things. If we're looking at grant restricted money, we still have quite a bit of COVID money. We have about a little over $900,000 in COVID money still waiting to be spent. And that's all earmarked as it relates to essentially really that bus barn. And so that was completed, the gutters up last week. And so the addition to that warehouse for housing the mobile unit is complete. So we'll have a couple of large payments as it relates to finalizing that. And then the majority, the rest of the COVID money will be spent on the payments for the mobile unit. So all earmarked and will be gone within the next year. Be good to get that off of our books. When we're looking kind of at our days cash on hand metric that we've spent some time on this last year looking at the end of July, we were at 66, a little over 66 days cash on hand. And if we're looking at where we were at in July of 24, it's up about 29 days from July of 24. And so if we're looking at what that really means, it's just the cash that we have available for not bringing in any cash in the door, how many days we would have cash to meet our ongoing expenses. And so we did see a little bit of a decrease in that from June to July. Like I said, cyclical balance with our cash, but we're at about 66 days at the end of July. Remember, the board gave the direction to have another 20 days within the next 2 years. And so if we're looking at 10 days each fiscal year, that would we need to be about 84 days at the end of this fiscal year. We ended June 30 at 74 days cash on hand. So we'll continue to manage and monitor that metric through the fiscal year and present that each month and showing where we're at as it relates to that. If we're looking at the statement of revenue and expenditures for July, we ended at the $31,000 net revenue compared to a budgeted loss of about $219,000. As we look through the financial statement highlights to just kind of point out some of the things that drove that bottom line, the 340B pharmacy program continues to be a significant resource to the organization. For the month of July, we're at net revenue of about $220,000 within that 340B program. And so we'll continue to manage and monitor that. Obviously, we'll see some changes within that coming in January of 26, but just to point out what an important resource that is for the organization and what it's doing to the bottom line for the financial statements. As we look through the other net revenues of the programs within RiverStone Health, the other significant one was the medical dental Ryan White clinics. When we look at the net revenue of that for the month of July, we're at about negative $152,000. Like Megan mentioned, quite a few things that we're dealing with staffing within the clinic that's obviously impacting revenue for that. I'll talk a little bit more about FTEs towards the end, but obviously the vacancies within those FTEs are causing a significant disruption in some of the medical side of those programs. A couple other things to point out. We'll go through some of I think Jim wanted me to talk a little bit about the price volume impacts that are on the financial statements that are included or the financial highlights that are included in the packet. And so if you're following along on the second page of those financial statement highlights, about middle of the page, we have a breakdown of patient services revenue for medical clinics. And essentially what this is doing is looking at what the impact was as it relates to the reimbursements or the price that we received for those services versus what the impacts were for the volume or how many visits we completed for those. And so if we're looking at that price volume impact for the month of July, we actually had lower than average reimbursement from budgeted, about $5 per visit. But when we're looking at the volume impact, we had less than budgeted visits, about 155 less visits. And so if we're looking at what drove that negative bottom line of 73,000, it's both a combination of the price and volume of the funds. Any questions or anything you want to elaborate on with Jim?
No, that
Okay.
makes sense to folks.
Last thing I think is important to point out on the financial statements for the month of July is the wages and benefits variance. And so we had budgeted a little bit over 3.3 million and we came in a little bit over 3 million. So a variance of about $266,000 for the fiscal year. We did have variance through pretty significant variance to the end of last fiscal year, but budgeted a little bit more conservative this year. And what we did is we budgeted everybody's leave at the attendance policy. So it should be a little bit more in line with salaries and benefits. What's really driving that is vacancy savings. So also aligning to the conversation about the vacancies within the clinic. Our budget for fiscal year 25 assumed, or excuse me, 26 assumed 353 FTEs, but through July, we were at about 319 FTEs. So down 34 FTEs from our budgeted. So that's a pretty significant savings, not probably in a good way to us organizationally through the first month of the fiscal year. I think it's also important to point out, went back in history a little bit, because in August, we saw that drop to 312 FTEs across the organization. The low for the organization that I can find was in fiscal year 17, which was 326 FTEs. So that would be a new low for us in FTEs for this fiscal year. So it's just an important thing to recognize. Only other comments I have from the financial side is we just had our financial auditors on site last week doing their on-site work. And so they'll continue through the next probably month, wrapping up their audit and going through some of the final procedures that they have. They're still waiting finalization of their accounting standards for the year. And so I suspect we'll see a natural lag in our financial statement audits as we always do. But overall, it went good.
Any questions for Shanna? Comment. Bill,
See if I can free up about 3:20 so we can leave. Otherwise, we'll for sure free up at 3:30 and
Question, Lionel?
we should probably try to leave.
Oh, are you ready for me?
Right.
Okay.
Oh, there's feedback coming out of one of the people online. We
Oh.
couldn't tell the question. All right, hearing none for Shanna, then let's move on to the next report, which is Lionel.
There you go.
All right. Well, coming to you from rainy, overcast Michigan. So, in any case, today or this month, the Safety and Quality Committee, I think, should be renamed the Safety, Quality, Data, and Reimbursement and Improvement Committee, because I think that's typically what we talked about at the meeting, and we had really three different primary topics. One was home health, one was hospice, and the last one was scheduling. So the first item, and I think it would be important to describe a little bit about what's going on with home health, so if you read the notes, it talked about a thing called LUPA, or Low Utilization Payment Adjustment. That's used by Medicare and the VA, and it's a system by which there are minimum visit thresholds for patients on home health, between 2 and 6 for every 30 days, and it's based on complexity. And if you don't meet the specific criteria, then you could suffer up to a 50% loss in payment. So this is a big deal. So RiverStone Health Analytics That's what it was called. I guess, is that a separate department? I don't know. Anyway, developed a report that includes things like, lots of details: patient case mix, weight, functional score, comorbidity score, the LUPA visit threshold, visits completed, and then it's reviewed by the group, and then they decide and they determine who should go out and visit that patient. It used to be, before this, that everybody would go out and visit these patients. So some patients got way too many visits, some patients didn't get enough, and our reimbursement was suboptimal. So that is, we think, now been fixed through this use of our information system, and hopefully everybody is happier because of that. The second has to do with hospice. And it used to be that CMS, Centers for Medicare, used a tool to determine, how, again, has to do with the reimbursement, but it used to be called the HIS, or Hospice Items Set, but now it's called HOPE, which is Hospice Outcomes and Patient Evaluation. And so instead of being a score assigned to people on admission to hospice, and then at the end, now it's at the beginning, during the middle, sometime at least once, and then at the end, and it uses a lot more data points instead of just what was it? I have it written somewhere. Shortness of breath and pain. Now they're also assessing nausea, anxiety, diarrhea, constipation, and agitation. So the purpose of all this data collection is that this is now going to be utilized in the care compare, the star ratings, and in our reimbursement. So this is really important. So the analytics team are, and by the way, this new system starts in about a week. It starts on October 1st. So we have to use this new system, and we have to get good. By the way, in the background, you might be hearing an espresso machine, so don't worry about that. Anyway, so that will be used. And then the final topic that we covered was how Microsoft Teams is used. There's a section in there, I think, called Shift, the Shift app, the Shift application. So it used to be that our teams would have a calendar set up. It was a paper calendar, and it was only available, at the home base. And now it's gone all electronic, so that they'll be able to better coordinate, who goes where, when, that sort of thing. So those were the three primary topics. I talked a lot more than I wanted to, but that's it.
Thank you, sir.
Questions?
Any questions for Lionel? Hearing none, can I get a motion to accept the report?
Second.
All in favor?
Aye.
All right.
Thank you. And apologies for my forgetfulness. Let's pull both back to finance. Can I get a motion to accept the September 18 notes, meeting notes? Second?
Second.
Motion, all in favor?
Aye.
And an acceptance of the financial statements, the July statements. Motion, please.
So move.
And a second, and all in favor?
Aye.
So moved by the board. All right, public health. Brent, you will be up.
Well, we had basically two topics. The first was the effect of the big, beautiful Bill Act. Is that the A Act?
Oh, Bubba, yes.
Yeah, it's OBBB. But, and as you see, we've got about 3 pages of the effect of that. Generally, there are cutbacks. There's
I'm
something.
happy to share.
Yeah, okay.
I have an updated highlights for folks. Yeah, I'll put it up on the screen for y'all. If I can do that effectively here. Yeah, there we go. So real quick overview. the national impacts estimate roughly 15 million individuals are set to lose health coverage somehow, either within Medicaid rollbacks, changes to the HCA marketplace, or other changes in the enhancements in the bill. And so it does a couple things. It sets forth work or community engagement rules, aligns for more frequent eligibility checks instead of once a year, now twice a year, every 6 months. Provides limits for state financing tools, which does not impact Montana, but affects many other states on how they limit their provider taxes. Montana fortunately falls under the HR1 cap at the moment. New copay and cost sharing authorities within this bill, as well as the $50 billion rural health transformation program. And so several key impacts as it relates to us within work requirements. When originally passed in the state of Montana in 2015, Medicaid expansion, the bill, or the HELP Act as it's known, already included creation of workforce programs, continuous eligibility, and cost sharing premiums and co-payments. However, we were never fully able to in the state implement some of the provisions in the HELP Act. They were required in 1115 waiver, and that 1115 waiver is a request to CMS from the state requesting to utilize federal funds in Medicaid for innovative programs on how to manage Medicaid within the state. In 2019, our first waiver was not accepted by CMS and the Biden administration. However, this month, DPHHS submitted a new 1115 waiver that aligns not only with the provisions of Montana's HELP Act, but also requirements under HR1 or above. And it requests that Montana be allowed to implement work requirements next year prior to the 2027 deadline set forth in the bill. There are a bunch of exemptions and qualifying activities that need to be met by folks across the state of Montana to comply. The good news is that over 90% of Montanans, based on current data, already meet these work requirements and community engagement requirements set forth not only in HR1, but within our 1115 waiver request as well. So essentially what we're doing is spending upwards of $50 million. A new report actually just came out yesterday sharing that we've talked about Georgia in the past and how our systems are similar and how they administer community engagement efforts. A new report yesterday shared that Georgia spent $54 million just on the administrative costs and burden and overhead on staff and systems within their state government to administer work requirements. That's not even adding the cost of patient care that was associated. That is simply in setting up the systems and the staffing for administering work requirements. So keep that in mind, $54 million. 10% of our Montana Medicaid population that might not meet that is 12,500 Montanans. And so we are potentially going to see a state bill upwards of $40–50 million to manage 12,000 Montanans. That's what we're currently talking about. Eligibility redeterminations every 6 months is coming, and this is guaranteed. DPHHS has assured us that this will be based on date of enrollment, not a one-size-fits-all at the like we saw at the end of the public health emergency. So our concern there was, is this going to have the same impact that redetermination had a year and a half ago? And all signs point to no. However, it's still going to require additional staff. Hearing this week, DPHHS said that they would need between 40 and 50 additional staff to help manage this process and program. We fear that folks are going to lose coverage even if they are eligible due to processing delays. Montana's last in the nation in terms of timely processing of applications. And success here is really going to be determinant on the full implementation of House Bill 601 that passed last legislative session, allowing for the Medicaid Assister portal to go live, where we as FQHCs, community health centers, and public health will have access to the application portal system and be able to help applicants in real time. Improved data analysis and system functionality at the state is also supposed to allow for further additional ex parte renewals. And ex parte means using the available data that the state has from SNAP, from TANF, from other systems to help process that data rather than relying on reapplication time and time again. So time will tell what that ends up being. This is just a chart that shows us for expansion applications in the state. We are at the bottom. We are 50th in the nation for timely application processing. So that is a concern that Director Brereton and his staff are working hard on addressing, and they know we need to get further. Additionally, we're at the bottom in terms of retention rates and ex parte renewals, as well as renewed coverage for folks. And so out of the 200 to 230 enrollees in the state, we continue to see decreases in enrollment rather than stability. So we'll continue to monitor that. One of the things that we're worried about is the risk of uncompensated care and shifting costs to providers. And so we're seeing a little bit of a blip now with redetermination in the millions of dollars in hospital uncompensated care costs. And so we'll continue to monitor that, as well as changes with the marketplace. HR 1 OBUBA did not extend the enhanced premium tax credit. There is still time to take action on that in Congress. Polling suggests that extending that tax credit could help folks get reelected across the country. And so there is some political pressure to extend that. However, if it doesn't, we're going to see more folks drop off the ACA marketplace at a time when our navigator system across the state has been gutted. So the folks that sit down and work with individuals through Cover Montana help those high risk folks and those high need folks understand the application process. They are no longer available as a resource for us. Cost sharing is also way more complicated than it needs to be. The bottom line on cost sharing is that while federal law prohibits premiums and Montana law prohibits copays, Montana is asking in our waiver to allow the charge of monthly premiums, and the feds are asking us to initiate copays. And so copays are not allowed per Montana law, and premiums are not allowed per federal law. And so there's going to be some fun reconciliation that needs to take place within the 1115 waiver process, and most likely in the 2027 legislative session. All that to say, Congress is trying to make up for all of these cuts with the rollout of the Rural Health Transformation Program, $10 billion a year through 2030. Montana's guaranteed to get at least $100 million. Hopefully we'll get much more. We're expected to have some robust funding in this. We submitted an application on behalf of RiverStone Health and the Montana Family Medicine Residency Program in joint with almost 50 other critical access hospitals and entities across the state with Billings Clinic to help meet some of these key needs and drivers. So we submitted that information to the state. The state will distill that down, and then it's DPHHS's responsibility to apply for the state of Montana and all of our stakeholders to Health and Human Services to receive this money. So we provided our application. The Hospital Association and Primary Care Association submitted another application to the state, and Intermountain Health submitted their own application to the state. And so we provided them with a ton of information on how healthcare providers can utilize this funding to improve access, quality, and resourcing. And we'll see what happens at the end of the day. But there's your more succinct overview.
Thank you. As you can see, being chair of this committee is very easy. Because I've had John report on the first part. And the second part was the report from Megan Gibson, who has the new position of Behavioral Health Systems Improvement Manager. And she is on our program for new business, so I have nothing else to say.
Thanks, Brent.
Any questions for Brent or his surrogates today? Hearing none, I need a motion to accept policy committee's notes.
So moved.
Second. All in favor?
Aye.
Have any old business to come before the board this morning? Hearing none. What's going on with behavioral health, Mr. Forte?
All right, I gotta keep talking. Let me share our gap analysis. Go back into the meeting here. Sorry, guys. So while I'm doing that, I'll actually defer and call Megan Gibson up first so that she can introduce herself and say some things on our Behavioral Health Systems Improvement Coalition that we are actively rebuilding around the Yellowstone County area. Morning, Megan.
Yeah. Thank you for having me. I'll just introduce myself. Like I said earlier, I'm the new Behavioral Health Systems Improvement Manager. So my work is primarily as a coalition and community organizer with RiverStone Health and our community partners and stakeholders in Yellowstone County. And my work is to identify and improve service gaps for behavioral health systems. So right now, kind of what I'm working on is the crisis diversion coordination, that information management. So providing oversight to data reporting for funding, leading ongoing sub-grantee meetings and communication of updates between partners. So that looks like completion of our quarterly report that's coming up soon, using data from sub-grantees, but also community stakeholders of how our crisis response system is working in correlation to the crisis response model. So someone to call, someone to respond, and somewhere to go. That includes ongoing communication and consultation also with the state and Montana Public Health Institute on best practice and grant needs, but also community needs of what we're seeing here in Yellowstone County as our primary needs come out within our data. We're also looking at mobile crisis response planning with stakeholders. In addition to the crisis diversion grant, I'm also the Behavioral Health Coalition Coordinator. So that is taking on the previous work of Substance Abuse Connect, but looking at taking a step back and expanding upon that. So we're looking at a broader behavioral health look for this coalition that is inclusive of substance abuse as well. So I act and oversee as the primary point of contact for the coordination and facilitation of this coalition through organizational support and ongoing communication there. So right now we're looking at bringing together executive committee within the next month, possibly month and a week or two, and planning the organization and timeline of the coalition. So how we want the structure to look, the timeline for the next 6 months to a year, and our goals there. And looking ahead at resource mapping and a strategic plan. So we want to develop a strategic plan by summer regarding behavioral health systems, inclusive of substance use. In addition to that, we want to understand the many funding sources that exist for behavioral health in the county and at the state and federal level as well, and how we can really consolidate our efforts to ensure all funding is used strategically between all of the many partners that exist in our community, and really promoting working together to identify those gaps and how we can look at improving our systems as a whole. In addition to that, I assist with some staffing for the Montana Opioid Abatement Trust, so providing organizational and coordination support and kind of linking that coalition work to this committee. For example, in terms of how our system is identifying those gaps and how committees outside of the work can support those gaps. Because a lot of additional groups are wanting to improve upon behavioral health systems in Yellowstone County, but we want to make sure all of our efforts are coordinated and working towards a plan together. And then through all of those systems and bullet points there is ongoing community collaboration. So working between all of our partners, stakeholders, and different organizations that already exist and are doing this good work, and promoting ongoing communication. So to ensure that no one is being left out of conversation and that there's transparency in all of our work.
Questions for Megan?
What existed before the current organization? There was an organization before, but how was it?
Yeah, the new coalition.
Oh.
Yeah, so the organization before was Substance Abuse Connect, and that's been housed previously by different organizations, and really that work is now coming under RiverStone Health, just because it will be a great way to ensure that the work is done countywide. And we have a lot of data reporting measures and a lot of different work that's already done being the county health department and with RiverStone Health that can further support that work to ensure that, you know, data reporting measures are shared strategically and in a timely manner. So that's our goal with looking at this new coalition and it being under RiverStone Health.
Megan, you kind of mentioned a little bit about the mobile crisis response planning. Can you speak a little bit more about the timeline?
Yeah,
of
right.
Implementation.
Yeah, we don't have an exact date for implementation right now. We are looking at available funding sources and what we have available and working with our partners to see what can be implemented strategically, possibly in the interim, versus what is needed community-wide to really promote sustainability of a program here. So we're still in ongoing communication of what the best next step is, but we're engaging our stakeholders really effectively and working with the state on that as well.
Did the transition here come with the resources that were previously allocated to that effort? The vehicles, the people?
Yeah.
Okay.
Yeah, so we're still working with a lot of the same key partners and a lot of the funding sources, but really trying to further define the previous work to ensure that our future plan is more sustainable while using the funding sources that we have available to us.
So not that it shifted or came to us, but it's still out there in existence with fire, EMS. Resources with the city remain with the city, those with the county remain with the county. And so Megan's really working with all of those folks, Rimrock included, you know, everybody that was a part of the trying to put the puzzle together, understood, do the postmortem, understand why it failed in the first place, and figure out how we move it forward and make it successful in the future.
The goal of that still what was previously represented as call diversion for public safety. Is that still a focus point in that conversation?
That's, yes, it's a key part of the crisis now model of saying, how do we get the right resource to the right individual?
What is that called diversion?
So one part of this initially, and this was several years ago, was kind of the discovery that there's a what was represented at the time, a significant number of calls that come in through various sources, but they come to the 911 center, and for lack of any better resource to deploy, folks experiencing some sort of crisis would receive either a fire truck, ambulance, or a police officer, or all three, and none of which really they probably needed. Those were just simply the only resources available to them. An element of this initial implementation several years ago by the city was the development of a resource more applicable to those crisis situations that didn't involve any sort of crime or immediate medical emergency, in the application of care providers that focused on that crisis, as a way also to more appropriately utilize fire, medical, and police responders. And there was some initial thought, fairly serious impact to the availability of those resources to more applicable scenarios, as opposed to being where they are. I don't know that that benefit was ever realized by the city's initial implementation, but I think from my historic chair down at the 911 center, there's certainly not a lack of work. So,
Yeah, I think I'd characterize the model as more partnered response. So when Substance Abuse Connect under Zach began the mobile crisis response, the city council felt very strongly that it shouldn't supplant other first responders going out. And so what they did is they set up a model where the mental health clinicians go out in a coordinated response with another first responder, either the fire department or the police department. And I think that's what most areas around the state are sticking with. But I think where the diversion comes in is from inappropriately taking people to jail or inappropriately taking people to the emergency room. And then in some cases, being able to free up those other first responders more quickly than if they were out there themselves and then handcuffing people, driving them to the, you know what I'm saying? So I think that's where the real diversion benefits come from.
Megan, out of your gap analysis, is there a single burning issue you see?
In terms of the most important work to address first. Right now, I think it's
Sorry. My fault.
really engaging our community stakeholders and getting everyone to the table and making sure everyone is represented at the table very well to just to ensure that we have all the information that we need, right? That we're not missing a piece of our system, whether that's our crisis response system or our overall behavioral health systems too. So right now it's meaningful engagement and getting people to the table to have great conversations about what hasn't worked previously and why, so that we can move forward and create other systems and really fill some gaps. And through this ongoing work with the coalition, we'll complete that strategic planning process right in the next 6 months. And that'll really have some great groundwork to build off of and to continue to engage our community effectively.
Will that define RiverStone's role in the network of providers?
Yes, that'll include RiverStone's work as well in terms of behavioral health and overall systems too.
Great. Other comments, questions for Megan? Hearing none. Thank you very much for your report. Good to meet you.
Thanks, Megan. So in the gap analysis, then, not for Megan's gap analysis of crisis and response, but we were asked by our local legislative leaders across the delegation here in the region to sit down and create a behavioral health facility gap analysis for the proposed Eastern Montana forensic behavioral health facility. And so in partnership with several part entities, including Billings Clinic, Rimrock Foundation, Intermountain Health, Community Crisis Center, New Day, Alternatives, Inc., Bridgemont, or the Mental Health Center, YBGR, the Boy Girl Branch, as well as Upstream and the Hope Coalition. We sat down and had a community meeting with our elected leaders and shared our overwhelming support, honestly, for the development of such a facility. The fact is, our state needs this facility, our region needs this facility, our patients, our clients need this facility, but there are some key issues that need to be addressed in the creation and the location of this facility. And so there's been plenty of public comment in the media and elsewhere. Mark Morse, Commissioner Morse, and I also spoke. He was engaged in this conversation and the development of this gap analysis. He and I will be speaking with the media later today on this project and sharing our collaboration and the approach that we should have been taking with DPHHS and other stakeholders from the very beginning. So we realize and recognize the need for developing such a facility, but we also wanted to share some of the key gaps that exist in our behavioral health system currently. You know, Dr. Littlefield said earlier, we have an educational pipeline gap. We have, 450% growth in trainees with only 26% growth in capacity to take on those trainees. And so not just in family medicine, but in behavioral health care, we have some severe educational and pipeline gaps that relate to workforce. We do not have enough behavioral health providers, whether those are PAs and NPs, MDs and DOs, or other associated behavioral health medical assistants or licensed therapists in our region to be able to effectively staff and sustain a new, 35, 40 bed facility that's being proposed. And so at a standard 7-to-1 ratio, that would require about 450 full-time for such a facility across our region. And those staff would honestly just come from RiverStone Health, from Intermountain Health, from Billings Clinic, and move from one of our other providers into this potential new facility. We need to build and recruit and retain the highly specialized staff that such a facility would mandate. We also don't have the step-down capacity currently, and this has been recognized by DPHHS. There are funds within the 872 Commission, the Behavioral Health for Future Generations subcommittee, that everyone recognizes across the state of Montana. We do not have a step-down facility for folks that get discharged from the state hospital. That in-between place for folks to go when they're leaving inpatient psychiatric care. And so the first step to sustaining a forensic facility would be to also build concurrently a step-down facility for our region so that we would have a place for folks to go. Right now, there also is a gap in housing and transitional living, but also long-term supportive housing. And so that ends up leaving folks vulnerable for recidivism, whether into the behavioral health system or the criminal justice system, and is a gap that we need to address. We also have an issue with incomplete, poor information at transfer and discharge from the state hospital. Behavioral health providers that we spoke with, the substance use providers and addiction therapy providers have all seen that a lack of coordinated discharge from our state facility is leading to a lot of problems, a lot of recidivism, and unintended discharge for folks. They are not getting discharged from the state hospital with sufficient plans, sufficient medication stores, or coordinated discharge planning. And so all of this leads to a capacity strain, not just on the crisis center, but on our emergency departments and other resources across the region. And so we've got to figure out, how do we create some short-term stabilization beds? How do we work with our short-term holding facility that is being built at the county jail to figure out resourcing, beds, placement, et cetera, for folks. And then finally, data transparency, system connectivity, and Medicaid payments. We are asking the state and others to help create a single accessible dashboard for tracking these core metrics, tracking discharges, tracking patients throughout the behavioral health continuum of care, so that patients don't fall through the cracks. And if we're going to be successful at all, we need to see Medicaid reimbursement keeping up with inflationary costs. We need to see Medicaid reimbursement in behavioral health, substance use treatment, keep up, so that we can continue to pay our staff, and other agencies can continue to pay their staff a living wage and recruit and retain the best possible professionals to take care of these patients throughout our region. So that was the analysis. I had the opportunity to share that with the intern committee on children, families, and HHS earlier this week. And we'll be sharing additional information and trying to get some answers from DPHHS shortly.
You mentioned the step-down facility and the need for that. I assume that there's not been any consideration and any financial planning for that. Is that correct?
I think the other main point in this, and why we were asked to do this by the legislature, why we put this gap analysis together, was to just, quite frankly, show DPHHS and the state of Montana that Billings, Yellowstone County, Eastern Montana, we got our poop in a group finally. We have groups of connected providers working in the same direction, asking for the same things. And it has always been this piecemeal, I'm going to go over here, and you're going to go over here, and we'll go over here. And we still have some of that. But we needed to show a united front to say, listen, state of Montana, Billings is a great place, and we are working together in a coordinated fashion to try to fix this problem. Now, talk to us. Let us provide you with some input, instead of just saying, hey, you know what, we're going to put this in Billings, we're going to throw it over there on the eastern side of the state, and we're going to do it whether you like it or not. Probably not the right approach. Now let's try this collaborative approach where we can talk about these things. There's funding within the 872 BizFig money for step-down facilities, for other, building capacity and filling in some of these gaps in the continuum. This is our effort to begin conversations with the state and the administration to collectively ask for those for our region.
I just want to add, the thing is, severe people who end up getting hospitalized in these facilities have severe decompensated mental illness. And mental illness, severe mental illness is treatable, but it requires lifetime treatment and support. This isn't like you go in and you get some medications and then you get discharged and you go on your, and you're treated. These facilities are meant to stabilize people who are in complete crisis. But if you stabilize them and then just discharge them out into the community without intensive step down and then intensive community supports, it fails. It doesn't matter how fantastic your institution is, that model fails. And those folks end up on the street, they end up back in the correctional system, they end up committing crimes, they end up, really not being able to survive. And so really the only way forward, no matter where they put this facility, and I do think that Billings has the network, to offer that support, but not in the current state. That support, that community support, it's not just about building the facility. That community support requires investment. And continued investment. It's not just like a capital project where you invest it in and then great. We really need to build that network of continued support. I take care of a lot of these patients. We have seen a trend where people get discharged from Warm Springs and their psychiatric care gets taken over by us here as primary care physicians and with our behavioral health team. And that's okay. We can't take more of that without more people in the community stepping up for that support so that we can have these folks living successfully in the community in supported, environments. And so I just wanted to share that perspective as someone who's treating, many of these patients.
There's a provider shortage.
There is a provider shortage. We need more psychiatrists. So our providers here, I will say, are some of the best, I would say, in the country with managing complex mental illness. Like, we really train our residents. We see a lot of that here, and we really train and support our residents. We have a psychiatrist on staff and that integrated behavioral health model. We were early adopters to that model in the country, and we do a really good job at that. But there still are people who need even a higher level, that top of the triangle support, and we need more of those providers. What I would say even more than that, though, is we need supportive services, because it's not just about choosing which mood stabilizer, what antipsychotic, and at what dose to prescribe. That's a piece of it. But really, it's how do we then help those folks to function in society? How do we help them to get their meds? How do we have them in stable housing? How do we have social supports with people who are coming to their house and checking in on them and including that, and so that's the piece that I would say we need even more than those of us who can write the prescription.
Yeah, and I wasn't just speaking of the highest level of providers, the therapists and other people.
Yeah.
Terrible shortage.
Yeah. Yes. Yeah. And it's not funded. Partly why we have a shortage is because it's not funded well. Yep. There are models in the country of intensive PACE programs where they have, and our mental health, they still have it, but it's so defunded in our state that it's not really able to operate in the way that it's meant to operate, where you really discharge people who are able to live outside of an institution, which is better for them, better for everyone. But then they have a whole group of people that come alongside them to make sure that they're succeeding in that environment. And that's a huge piece that we're missing.
A lot of the funding, I should know the numbers, but I don't. But a lot of the funding is through the Medicaid system, not commercial insurance, not Medicare.
Right.
So when you look at the U.S. population, a lot of it's coming from that low reimbursement payer.
The folks that are the most persistently and highest acuity mentally ill folks are the folks that are not able to hold down consistent therapy. benefits, right?
Yeah.
So they are the folks who are reliant on Medicare, Medicaid. A lot of them are Medis, Medicaid, Medicare, because they're on SSI insurance.
Yep.
And so, yeah.
I know there was some conversation recently about reevaluating the placement of the facility. More maybe an approach to having the initial conversation rather than, as you said, just putting it somewhere and picking and you're gonna have this and welcome, we're here for the help kind of a thing. What are the ramifications if that effort comes back and says, hey, we're gonna put this in Ekalaka? What are the ramifications to the community and to RiverStone?
I think no matter where they put this facility, you're gonna have the same gaps.
Okay.
You're gonna have the same issues. And so that was our conversation with DPHHS committee was you could put this anywhere you want to put it. You put it in the middle Flathead. But just because you put it in a population center or a rural frontier place like Ekalaka or Scobie doesn't mean that it's going to be more successful. It's not. I think there was this conversation that it's a NIMBY issue. It's well, it would just not in my backyard. Put it in the middle of nowhere, right? And we see that with the current state hospital facility. You know that Warm Springs is not a bustling metropolis where everybody's dying to live.
Right.
Folks are coming there because the state hospital is there and they're service-minded, mission-minded individuals that want to take care of the population. But you still have staffing issues. They still can't get the right staff to sustain that facility and keep it successful. And so that's been the conversation with TPHHS. Yes, I understand, Director Brereton, you feel like this is the population center is there, so the workforce is there, and therefore it'll be more successful. I appreciate that. Help us help you make Billings the cool, best place to live in the state so that we can attract that qualified workforce, so that we can build programs at MSUB and Rocky that are, psych and addiction med specific. Build all of these things. We applied with the Montana Family Medicine Residency Program to receive an addiction medicine fellowship this past year. Our application did not get accepted for whatever reason. So we do not have an addiction medicine fellowship in Montana, Wyoming, South Dakota, or North Dakota. The closest one is either Salt Lake City or Denver. And that was one of the things that we were trying to do to build this pipeline, to build the resources. And so the conversation that we had with our elected leaders at the federal level was, hey, that's great. Let us know how we can support your application. And we did, but we still didn't get anything. And so I think our approach is, how do we bring a unified front from regional, healthcare providers, regional elected legislators, our federal legislation, and say behavioral health, suicide, substance use, addiction is a problem in the state of Montana. And this is a collective way that we are going to solve that issue. And so addressing these gaps is really just the first step to say, hey, you can put this thing wherever you want to put it. But we kind of agree with you. Billings is probably the best place. But if you do it tomorrow without consulting us, it's going to run into a lot of problems.
Okay. Thank you.
Any other comments, questions about behavioral health? Hearing none, before we adjourn, Carrie's double checked with me that I did get a motion to accept policy committee's meeting notes. Thought I had, but I'm an old man who can forget.
So moved.
Second, all in favor?
Aye.
Aye.
Anything else for the board this morning?
Y'all should have an invitation Do you have that, Karen? Thank you.
Get one in the mail.
Yeah, that's okay.
Save the date.
Save the date, the city of Billings requests your presence at their annual boards and commissions volunteer appreciation dinner, October 29th at 6 p.m. So invites will be mailed to your personal address, but I just wanted to share that with folks on the Board of Health that you are invited to the appreciation dinner on the 29th. It's usually over here in the Esper over at the senior center. Yeah. So more to come on that, but save the date for October 29th. Probably wear your best Halloween costume too.
Come in costume.
Tell them John sent you.
Theme. You have a Board of Health theme.
It's 9 days after National Bigfoot Day, by the way.
So a quick roundtable, Coach. Any comments about this morning's meetings?
Good meeting.
Brent?
Yeah, good meeting. I guess I'm looking at this. I guess one thing that would really be handy to have is which one page was just devoted to the individual service. Kind of nice list. Wage program, residency program.
The meeting, I appreciate the involvement of staff and the explanations and details to the questions. It's actually very helpful. Yep.
I have none. Michael? Nothing. Ready to do rate volume splits for me? Show me how to make those calculations.
Okay.
The finance variance.
I'm working on
Okay.
it. It'll take me a little time. It's not a problem with, it's my problem.
You're sitting next to someone who can help you with it if you, Carol's right there. So.
Yeah, like I'm here to help you. And I'm good. It's good meeting.
Jim, you had a fall, you recovered and everything, you got,
Yeah, I just had a medication issue
yeah, but
and
because we heard you fell off a ladder or something.
no, I just fell in my kitchen and bounced between cabinets. So they spent 3 days in the hospital diagnosing issue, Coach.
Casey Wheeler said he's now working at Intermountain and will be able to make many more meetings.
Oh,
Excellent. Great. Me, Carol?
I'm good.
Oh,
Yeah.
Lionel,
Yep.
sorry. Anything, Lionel?
Yeah, I thought that today's meeting was particularly dense with important topics and information, and so I appreciate everybody's input. It was a good meeting.
Glad you didn't say today's meeting, the board chair was particularly dense. May have heard finance people say in the past in this chamber, patient volume drives the economics, patient care activities. What Shannon and staff are doing is breaking that down one level so we can see, besides volume, the impact of the different services or payers that are occurring. So a simple example, if we saw one patient a day that had $10 of revenue, if you saw two patients today and had $16 of revenue, you would have both rate and volume variances. Volume variance would be 10 positive, your rate variance would be 4 negative. Did I do that right?
Sounded good.
It's been a long time, so. And we see it you see it, bean counters see it in all areas of patient operations, clinical operations. And now that I've bored you again to tears, we are adjourned.